Hey everyone, welcome to Medcomplete Board Review. My name is Dr. Adam Atut. I'm the founder of Medcomplete. I'm a practicing physician in New Jersey, and I currently serve as the residency program director for the transitional medicine residency in Hackensack Palisades Hospital. The reason why we created Medcomplete is to help medical students, residents, and doctors, and even mid-level providers to help improve their medical knowledge tremendously. The goal here is to help you guys learn medicine at a very, very high level where you're able to help your patients, which is ultimately everyone's goal. This is why we went into the medical field. I truly believe that you should not have to pay a tremendous amount of money in order to do well on the medical boards or keep up with your medical knowledge if you're a practicing doctor or a mid-level provider. The information should be made available and the teaching to it should be made available to all. So what you're about to see in this video are 10 cases of how we break things down. There'll be 10 cases of high-yield medical cases that will, most likely these topics will come up on your medical boards, whether it be Usmle, the medical exam for medicine or family medicine. And the way it's structured is that you'll have the question read out, it'll have a 5-second pause, it'll prompt you, and it'll let you know to pause the video. So pause the video, try to come up with the answer. Not only is the answer important, that's one aspect of it. The most important thing is for you to understand the topic of why things are the way they are, the pathophysiology, and how things could be changed on the exam. And if you truly understand it, no matter how I twist the question around, you should know that C is the answer or A is the answer, and because you have mastery of the subject. And again, that's our goal here. So once it pauses, give yourself 5 seconds, try to come up with the answer, and then when you unpause it, you'll have a very, very detailed explanation that goes in depth into the topic and hopefully help you do better on the boards and in real life when you're taking care of your patients. All right, I hope you share this all with your colleagues. You know, let's spread the knowledge. Let's make everything available to everyone so that way we all do better for our patients. All right, see you soon. A 66-year-old male with no past medical history presents to the emergency room with chest pain, dyspnea on exertion that began 1 hour ago. Of note, the patient arrived from an 8-hour flight 1 day ago. CT/NG reveals a pulmonary embolism. If present, which of the following would make the strongest case for thrombolytic therapy use in this patient? And so the answer to the previous question that we posted about the pulmonary embolism is E, hypotension, okay? So whenever you're approaching these patients who have a pulmonary embolus, either on the exam or in real life, it's very important that you approach them in an organized and systematic manner, okay? So you want to subdivide these patients that have an established diagnosis into 3 categories. Either it's simple, uncomplicated PE, a submassive pulmonary embolus, or a massive pulmonary embolism. And simple uncomplicated is a patient that has a PE and doesn't have any of these things. They're not hypoxemic. They do not have an elevated BMP, no elevation in troponin level, and no ventricular strain either on CT or echo. And those patients oftentimes can receive outpatient treatment. They can just get anticoagulation in the ER, and they don't actually need admission. They can be discharged. Submassive and massive pulmonary embolus, it becomes a little bit trickier. So massive PE is somebody who has a PE with hemodynamic instability, specifically hypotension. So this is someone where the pulmonary embolus has caused significant hemodynamic compromise, and the treatment for these patients is oftentimes systematic TPA, okay? Systemic. Now, if systemic TPA is not adequate or is contraindicated, then surgical thrombectomy would be the next thing that we would do, but that's oftentimes risky and the patient has a very high mortality rate with it. Submassive PE is the patient that has these things, but does not have hypotension, does not have hemodynamic instability. So that's the patient that oftentimes can be a little hypoxemic, but more importantly has an elevation in BMP, an elevation in troponin, and those two are a marker for increased mortality in these patients and are a sign of right ventricular strain. Right ventricular strain can be seen on CT, but it's much better evaluated on an echo. Okay, and you can, sometimes they can describe it as right ventricular dilation. That's the same thing, okay? So those patients are hemodynamically stable, but have these signs, and they do need admission, they do need close observation, and generally speaking, you should get interventional radiology or vascular department on board for these patients to determine whether they need a catheter-directed TPA or not, and that goes case by case depending on the patient. Okay, I hope you found this helpful. If you have any questions, please post them in the comments. 2-year-old male with past medical history of liver cirrhosis and multiple admissions for alcohol intoxication in the past presents to the ER for a complaint of worsening epigastric discomfort after a night of drinking alcohol. The patient denies any changes in stool color, blood in stool, nausea, vomiting, or diarrhea. Amylase, lipase, and abdominal CT are all normal. The patient undergoes EGD, which demonstrates small, non-bleeding esophageal varices. Which of the following is the most appropriate therapy at this time? So for our patient who has esophageal varices and cirrhosis, the answer is A, not all. Okay, so it's very important that we understand a few things about esophageal varices, and it's very important that we catch these early. They're present in 30% of compensated cirrhotic patients, and they're also present in 60% of decompensated cirrhotic patients. The mortality rate for these, if they bleed and we don't intervene, is about 20%. So it's very important that we catch them early and intervene properly. So the reason why A is the answer is because Natalol is a non-selective beta blocker as opposed to metoprolol that is cardioselective. And the idea here is the non-selective beta blockers will allow for portal venous inflow to be reduced. So it will shunt the blood away from the portal circulation and therefore will reduce the congestion of flow within the esophageal varices and make the bleeds not as aggressive. Okay, they do reduce the bleeds. For every 10 patients that we treat with Natalol, we reduce 1 esophageal bleed. So this is very important. Metoprolol, like we said, is cardioselective, so it will not help in this situation. One thing that we want to notice is they commented on this as being a small esophageal varices, where medical therapy is superior to, let's say, endoscopic intervention. This is, again, for non-bleeding varices. But if you have a large non-bleeding varices, the recommendation is to do endoscopic intervention on these patients. So in case they throw that your way on the exam, you might want to go for endoscopic intervention if it is a large esophageal varice. If it's a medium size, the data is mixed on that. I don't think they'll test you on that. Octreotide is important in the setting of an active bleed. So if they give you a patient that's having an active esophageal bleed, that's when you would use octreotide. Again, this is a non-bleeding patient. And remember, if they are bleeding, they get octreotide, they get fluids, PPI, and another thing that's very important that comes up often is they should get antibiotics. Generally, the recommendation is to give them a 3rd-generation cephalosporin that does reduce mortality in esophageal variceal bleeds. Okay? Hope you found this helpful. Please leave your comments and questions in the section below. Hi everyone. Today we have a 38-year-old male with no past medical history who presents to you for evaluation of a tick bite. The patient states he was hiking in the woods 5 days ago. When he came home that day, he noticed a tick attached to his forearm, which he removed. He believes that the tick was attached for about 12 hours. Patient's currently asymptomatic and denies any rashes. He brought the tick with him and a picture is attached. Which of the following is the most appropriate? Hey everyone, welcome back to Medcomplete Board Review. So the answer to the previous question that we posted about the 38-year-old male who noticed a tick bite about 5 days ago is F, reassure without treatment. So whenever you see someone with a tick bite, either on the boards or in real life, it's very important that we understand a few key principles. Number one, we have to understand that tick bite, it does not equate to infection. Okay, they're not exactly the same. Not every tick bite equates to transmission of disease. Okay, so there's only a few specific situations in which a tick bite would transmit disease, and it's important that you not only recognize this tick by its description, so it's the Exodus tear tick, you have to recognize the name and you have to know what it looks like. Okay, so either one can be fair game on your tests. Okay, so this tick transmits Lyme, it transmits babesiosis, and it transmits anaplasmosis. So it's important for you to remember all these things. But the most commonly tested one is Lyme, obviously, because it's the most commonly transmitted. So if somebody comes in with a tick bite, you have to meet a few criteria in order for us to be concerned enough to give you prophylaxis. Number one, you have to identify the tick and know that it's the exodos tick. Number two, the tick has to be attached for 36 hours or more. Why is that? Because in order for the tick to transmit disease, it has to undergo a blood meal. And that usually takes the tick about 36 hours. So for us, either if the patient thinks that the attachment has been there for more than 36 hours, like that's their estimation, or if you see that the tick is engorged. So engorgement of the tick is equivalent to it having a meal, and that's equivalent to you saying it's been there for more than 36 hours. So either one of those is okay. And the prophylaxis that we would give must be given within 72 hours of the tick bite. That's very important here. So this patient was in the woods 5 days ago. We assume that that's when the tick bite occurred. And even if you give it to him now, the prophylaxis, it would not give him any benefit. It has to be within 72 hours. And the recommended dose is doxycycline 1 time, 200 milligrams 1 time. That's the recommended prophylactic dose. All right. So for our patient, not only is the tick not attached long enough, but he presented too late to benefit from the treatment. Okay. So that's why the answer is F. But guys, it's very important that you pay attention to this question, because all it could have taken is a few changes in a few variables here, and the answer could have just as easily been B. So if they said that the attachment of the tick was 40 hours and the patient presented 1 day ago to the woods, then the answer would be B. Okay, so be very careful with the details here. It's very, very tricky. The other thing is doxycycline for 14 to 21 days. This is the answer choice for treatment of acute Lyme infection. So if this patient presented to you and had the classic target rash, the erythema migricans, that would be doxycycline 14 to 21 days would have been the answer. Okay, Ceftriaxone, it's very important to remember this. We will do another question on this later. This is the treatment of choice for cardiac Lyme or CNS Lyme. So this is the patient that has a tick bite, then develops like third-degree AV block or high-grade AV block. They're going to ask you, what do you give him? Doxy will be there. It'll be the wrong answer. Doxycycline does not penetrate the myocardium, does not work on cardiac Lyme. So in that situation, you would use ceftriaxone for those patients. Okay. Amoxicillin is the treatment of choice in pregnant patients. So in pregnant patients, obviously we cannot give doxy. It's teratogenic. So in that situation, you would pick amoxicillin, but obviously in this case, it would not apply. That's why it's the wrong answer. Azithromycin is third line. So macrolides are third line for patients that have a contraindication to doxy, and let's say they're allergic to amoxicillin, then you would give azithro, but it's not as effective as the previous two. All right. I hope you found this helpful. Please comment your questions in the section below. Hey everyone, welcome back to Medcomplete Board Review. Today we have a 29-year-old female with a past medical history of type 2 diabetes. She presents to you for diabetic care. The patient's compliant with all medications and tries to follow a diabetic diet to the best of her ability. Her fasting glucose ranges from 95 to 115. Her 2-hour postprandial sugars range from 140 to 160. The patient's currently on metformin, 1,000 milligrams twice daily. Her physical exam is normal. Labs are below. WBC count 7,000, hemoglobin is 10.3, hematocrit 34.3, MCV is 70, A1c is 7.9, ferritin is 10, iron is 38, TIBC is 600. Which of the following is the most appropriate? Hey everyone, welcome back to Medcomplete Board Review. So the answer to our previous question of the 29-year-old female who's a type 2 diabetic is C. Give her ferrous sulfate. Okay, so this is a very, very important concept both on the boards and in real life. I've seen this way too many times where certain clinicians get confused by this and they see an elevated A1c and they give the patient another medication that makes them hypoglycemic. So if you notice here, the patient's fasting glucose is at goal. So her goal is to always be below 120, which is where we usually try to make these patients. And her 2-hour postprandial, as long as it's below 180, that's at goal for us, right? But you notice her A1c is not at goal. It's above 7, and certain clinicians can get confused by this. So for us to get this right on the board and to improve our patient's outcome, we have to understand two things. What is A1c? And if you understand that, then you'll understand how it can be falsely elevated or falsely low. So A1c is essentially how much sugar sticks to your hemoglobin, right, to your red blood cells. And the average lifespan of the RBC is 120 days. Okay, so if there are situations in which the RBC's lifespan is longer, so there is less cell turnover, that's going to give you a falsely high A1c. So what's an example of that? So anytime there's a deficiency in substrate that is required to make the RBC, the body's response is to slow down the production of RBCs and make them live longer, right? So that would be, for example, if you're low in iron. If you're low in iron, you don't have enough to make RBCs, so the body's response is to make those RBCs live longer, right? If you're low in B12, if you're low in folate, you're going to have a falsely high A1c, and you're going to see this discrepancy between this and the finger sticks of the patient. Okay, so this is why it's very important when you see these patients not only to look at the A1c, you should also look at their home logs and look at how their finger sticks have been. Things can also head the opposite direction on the exam. So they can give you a case where the A1c could be 6, but the finger sticks at home are, 250, 260, like completely disproportionate to the A1c. So if you have something that gives you a shorter lifespan of the RBC, so a hemolytic anemia, somebody who takes EPO or end-stage renal disease patients, those patients are going to have a falsely low A1c. So don't get tricked by this. Whenever you see that, your two options are either to correct the underlying deficiency, as in this case, so we would give her first sulfate. Obviously, adding glipizide and liraglutide, people who pick this are the ones who just concentrate on the A1c, and those patients are going to result in hypoglycemia, right? Obviously, adding insulin will also result in too much reduction in the sugar. So you can either fix this problem, which is the preferred way, and or the other option is to measure something called a fructosamine level. So fructosamine is essentially how much sugar sticks to your proteins like albumin and free proteins, and the lifespan of those proteins is generally 14 days like albumin, so you can almost get like a 14-day A1c, okay, and it would not get affected by the hemoglobinopathies or the iron deficiency. All right, so I hope you found this helpful. Please leave your comments in the section below. Hey everyone, welcome back to Medcomplete Board Review. Today we have a 77-year-old male with a past medical history of hypertension, type 2 diabetes, dyslipidemia, smoking, who presents for the complaint of chest pain. The patient's pain worsens after walking 2 blocks and improves after rest. The patient underwent a nuclear stress test, which was positive for ischemia. However, his coronary angiogram showed no significant coronary obstruction. The patient is currently on aspirin, losartan, atorvastatin, and carvedilol. His BP is 128/90, heart rate's 55 beats per minute. In addition to lifestyle modification and smoking cessation, which of the following is most appropriate at this time? Hey everyone, welcome back to Medcomplete Board Review. So the answer to the previous question regarding a 77-year-old male who's hypertensive, smoking, and has stable angina is A. You should start this patient on isosorbate mononitrate. So it's very important that we recognize stable angina and chronic stable angina, and we have to understand which medications are used to treat it and when. So the reason we're saying that this patient has stable angina is because it's predictable, right? He says that it's predictable. He knows after he walks a few blocks, he knows he gets the pain, it improves with rest, and the other criteria is that it improves with nitroglycerin, right? So this patient underwent an angiogram that did not show any significant coronary obstruction. So let's say nothing significant enough to stent or bypass, etc. So these patients that don't really have significant disease but still have symptoms, we assume that the cause of their symptoms is generally microvascular disease that you can't see on cardiac cath. So these patients, the treatment for them has to be systematic, and it really gears towards controlling certain things. So if they smoke, obviously they should smoke. Their blood pressure should be controlled. Their cholesterol should be controlled, right? We recommend they be on a beta blocker, which this patient already is on, carvedilol, and we shoot for a heart rate of like 55 to 65, right? Which he's already on. So let's go to our options and see why A is the right answer. So isosorbate mononitrate is a long-acting nitrate. It has been shown to reduce angina symptoms, especially if it's used in combination with an existing beta blocker. You can use beta blocker with calcium channel blocker as well. Like the combination of these two could have also been correct. The reason why it's wrong here is because the patient already has bradycardia, and if you add diltiazem on top, you risk him becoming symptomatic. So in those patients that they're already beta blocked, it's probably not a good idea to add both. If they're intolerant to beta blocker, you can absolutely use a calcium channel blocker in lieu of that. Okay, so ranolazine is also very effective. It's a sodium channel blocker. It does reduce angina symptoms, but it's not first line. Okay, so this is usually used if the patient's already on a beta blocker or calcium channel blocker. We use a long-acting nitrate and they're still symptomatic, then you can add ranolazine. The order of when to start these things is important on the exam. So you want to go to long-acting nitrate, beta blocker first, calcium channel blocker if they're intolerant, long-acting nitrate, and then if long-acting nitrate is not enough, you add ranolazine. So Celestazole is similar in that it does cause reduction in pain, but this is more for claudication, not for angina of the heart, right? It doesn't work on the coronaries, but this is used to relieve pain from claudication, okay? So you can think of it as like the Renexa of the peripheral vascular system, okay? Plavix, the addition of Plavix to aspirin doesn't really do much here. This is not an STEMI or a coronary event, so there's no need to do that. Spironolactone, again, doesn't help here. The patient's blood pressure is already somewhat at goal. So spironolactone would be helpful if the patient had heart failure, class 3 or 4. Remember that it'll reduce mortality in those patients, but we'll do a heart failure question at a later point. Couple of side effects about isosorbate mononitrate that we want to know in case they ask. It causes facial flushing and it can cause dizziness. Okay. I hope you found this helpful. Please comment your questions in the section below. Welcome back to Medcomplete Board Review. Today we have a 22-year-old male who has no past medical history who presents to you after having sex without the use of a condom. The patient has sex with men and states he has had 4 sexual partners in the past 3 months in which his condom use was inconsistent. He denies any symptoms now. He undergoes testing for sexually transmitted diseases, including HIV, which come back negative. In addition to condom use, which of the following will further reduce this patient from contracting HIV in the future? Hey everyone, welcome back to Medcomplete Board Review. So the answer to the previous question we posted regarding our 22-year-old male who has multiple sexual partners and inconsistent condom use is B. You should give him Tenofovir and Intressabeen to take once daily. So this is a topic that's going to definitely come up on your exam, and it's something you will definitely encounter in real life. Pre-exposure prophylaxis for HIV is very, very important. Worldwide, there are 2 million new HIV infections that occur every year, and those 2 million infections are preventable. Okay, so this medication and pre-exposure prophylaxis is extremely effective. It reduces risk of transmission by 95%. So simply by just taking this pill once a day, the risk of transmission is that much lower. So for the exam, you want to know a couple of things. You want to know when is pre-exposure prophylaxis indicated, and what are the certain things I have to look for. And we're definitely going to do more questions on this topic. But the reason this gentleman is a candidate for it is because he has multiple sexual partners and he does not use condoms consistently. So he's considered high risk for transmission. Okay, so giving him pre-exposure prophylaxis 1 hour before, this is something that was talked about, which is like point of, kind of like you can think of it as taking it, if you can predict a sexual encounter, you can take it right before. You can consider this, but it's not as effective as taking it daily because generally speaking, people don't always know when they're going to have sex. So we recommend for them to take it once a day. And the more they're compliant with it, the lower the risk of transmission. Okay. Taking it after sex, again, this is something that was hypothesized, and it's definitely not as effective as taking it just once daily. Okay. Tenofovir, Intressabeen, and Totegravir, this is a combination for post-exposure prophylaxis, and this is something we will discuss in a separate question, but essentially, like if they give you an exam question where a nurse got stuck by a needle or a physician and like the person is HIV positive or we're not sure the status, this is something you can give the patient to reduce their risk of getting HIV from that needle stick injury. Or you can even use it for sexual encounters in which the patient does not know the HIV status of the person they had sex with. Okay, but we will discuss this separately in a different question. Trimethoprim sulfamethoxide or Bactrim. This is used for PCP prophylaxis in patients that have HIV, once their CD4 count drops below 200. Also high yield for the exam, but it's not appropriate for our patient because our patient's HIV negative. One thing you want to know, guys, is when you give these patients PrEP, it's very important that they should be monitored closely. Again, we're giving them this because we consider them high risk. So these individuals have to come in every 3 months. They need to get HIV testing, STD testing, and they also need to get their renal function checked because Tenofovir and Intressabeen can cause acute kidney injury and is contraindicated once the GFR drops below a certain threshold. So you have to keep an eye on their renal function, okay? I hope you found this helpful, and please comment your comments in the section below.